before we move on to relapse disease and management for relapse disease, I just want to touch a little bit on MRD briefly, because it's been mentioned many times, and I would agree with what you just said, Dr. Allen. We are very focused in our clinical trial and our clinical trial design on MRD, MRD as an endpoint, MRD as a surrogate marker for depth of response and prolonged progression-free survival for MRD negative patients. But I wonder if I could ask Dr. Burke about what the utility of MRD testing is in the standard management of patients in the community. Is it something that's useful, or do we stick right now with fixed duration and stopping treatment at fixed duration, for example, with venetoclax-based therapy at 1 year for frontline and 2 years in the relapse setting?
Yeah, I think, you know, I think I'm somewhere in between. I think, Bill, you and other experts who've been doing this for years have probably been doing MRD on your clinical trials for a long time. And I think right now the average community practitioner is not doing it at all. And I myself am in a phase where I have increased my use of it, even, you know, off study. And that can be debated whether one should even do that. I think, you know, for me, what it is when a person finishes their venetoclax therapy, it's a prognostic tool, and it really helps that patient and the physician understand what is their likelihood of relapsing within the next few years. So as has been discussed, you know, these MRD negative patients have a relatively favorable progression-free survival and a low likelihood of relapsing, whereas the MRD positive patients are much more likely to relapse quicker. That is a prognostic tool, but it doesn't tell you what to do with the information. If a patient is MRD positive, should they not stop therapy? And continue the current course? Should they go ahead and stop therapy at 1 year or 2 years, whatever their defined plan was? Or should they switch therapy? Or should they add a therapy? These are all options, and I really think we don't know the answer to that question. And I think, you know, a trial like Captivate is going to start getting an answer to that, but these are really unknowns. So you'll hear opinions, but you won't really hear a data-driven answer to what is best for that patient. Likewise, I don't think we know what's the best duration of therapy for the MRD negative patients. You know, right now we have this defined period, and we can reassure patients that they're likely to do pretty well when they stop therapy if they're MRD negative. But would they be better off continuing therapy for a longer period of time with venetoclax, like you do with a BTK inhibitor? I don't think we know the answer to that question. So these are a lot of the unknowns that we're facing in the field right now. So should a community practitioner be checking MRD at the end of venetoclax 1 year or 2 years? I think I offer that as an option to my patients if they want to know the prognostic information, if they want to know, you know, what is their likelihood of recurrence within the next couple of years, then we can do that test. If they're not that interested and they're worried about cost and that's that sort of thing, I think it's certainly optional and can be omitted for routine clinical practice. There's my perspective on it.